Hi, everybody. Welcome to Empowering Women in Orthopedics Family Planning. I'm Elizabeth Matskin, and I'm super honored and excited to introduce our speaker tonight, Dr. Erin Kaiser. She is the Program Director for the Department of Gynecologic Surgery and Obstetrics at Brooke Army Medical Center in San Antonio. She received her undergraduate degree from the University of California, Davis, and her medical degree from Albert Einstein College in New York. She accepted a military scholarship and completed her residency at San Antonio Uniformed Services Health Education Consortium in San Antonio, completed her residency, and then went on to work at William Beaumont Army Medical Center in El Paso. During this time, she also served in Afghanistan and returned back to San Antonio, where she is now an associate professor of OBGYN and works with the residents and does a ton of teaching. She's very involved in their national association, and super, super excited to have her speaking with us tonight. She is going to go through a few objectives to include defining fertility so that we can understand age-related decline. She's going to compare different fertility preservation techniques and indications and discuss optimal timing and cost associated with egg freezing. So she's going to teach us and enlighten us and unlock the mystery and answer the questions that we don't always get to answer in orthopedics. So I'm not going to waste any more time, but Dr. Kaiser, thank you so much for being here.
Well, thank you so much for having me. And I am a general OBGYN, so I'm not a fertility specialist, but I am a program director, and one of my passions is wellness. And so I think this is a very pertinent topic as we're discussing kind of the workforce and burnout and wellness. So hopefully this will be beneficial for you all. If you guys have questions, feel free to just put it in the chat. I'll hopefully get to all of them throughout the talk, but if we don't, we'll look at those at the end. Okay, she went over the learning objectives. These are our learning objectives. All right, so the first question I often get are, do female surgeons have higher rates of infertility? So I just want to spend a few minutes looking at a few different studies. So this was the first one that looked at about 1,000 surgeons from various surgical fields to include general surgery, gynecology, orthopedic surgery, etc. They did show there was a 32% reported fertility difficulties. And we think about the national average rate of infertility is about 11%. So clearly much higher. 84% of those that did report fertility issues underwent an infertility workup, and 76% of those had to use some kind of assisted reproductive technology to conceive. On average, surgeons had 1.4 biological children, which is less than the national average. Their age of their first pregnancy was older, 33 years, compared with a national average of about 23. If they did require some kind of IVF or REI services, their first birth was usually at a later age, closer to 35. And the highest rates of infertility were seen in ENT, general surgery, and orthopedics. Here's kind of looking at that same study. The blue bar is our female surgeons, and the red bar is kind of the national average. So you see higher rates of infertility, needing fertility services, and utilizing assisted reproductive technology. Here, some of the questions people put out at the beginning was about, should I have a baby in residency? Well, here is in that study, it asked, the blue bar is they chose to have their first child during residency, and the red bar is they had their first child in practice after completing residency. And I do think it's interesting that the fields that said they had the highest rates of infertility, you kind of see those are the ones that tended to wait to have children in till they finished residency. And when they looked in that study at the cause of infertility, the biggest was unexplained, but kind of the biggest clump of things was kind of maternal age, premature ovarian failure, and ovulation, all the things that kind of correlate with waiting until a later age to try to conceive. This study I thought was interesting because they actually compared female surgeons to the spouses of their male colleagues. And overall, they noted that there were higher rates of miscarriage or pregnancy loss, more than twice the rate of the general population. Female surgeons had fewer children, were more likely to delay having children due to completion of residency training, were more likely to use assisted reproductive technology. In addition, they also saw higher pregnancy complications, and that was significant even when controlling for age, work hours, IVF, twins, etc. And they did show that females who operated more than 12 hours per week in that last trimester did have higher rates of major pregnancy complications than those who chose not to work or operate as many hours in that last trimester. This objective was a little bit different. It was thought to kind of characterize the cost and the workplace support for not just kind of infertility, but they also kind of looked at just the more diversity in our specialty in terms of like same-sex couples and just needing to adopt or surrogacy. And again, they found when compared to male surgeons, female surgeons were more likely to delay childbearing, have fewer children. A third of the surgeons that did require use of reproductive technology spent more than $40,000. Most took very little time off work. And their kind of conclusion or their kind of goal of this was to say that, we must enact policies and practices to normalize it, support people taking time off, expand parental leave, etc. And then this looked at occupational reproductive hazards. Again, more likely to delay childbearing, higher rates of pregnancy complications, and really kind of saying the culture of medicine needs to change. But what I found most interesting about this study was this comment, that this compared non-surgeons to non-physicians to surgeons, like all physicians to surgical specialties. But out of all of them, only 8% of female physicians surveyed said they had been educated on the risks of delaying childbearing, which as an OBGYN, I felt was shocking. So that's the point of today. Let's get educated on fertility. So let's start with just a basic overview of what is infertility. So technically, the diagnosis of infertility is you try for a year of having unprotected regular intercourse, and if after 1 year you don't get pregnant, then technically you meet the diagnosis of infertility. We change that a little bit with age. So if you're 35 or older, we say try for 6 months, and if you don't get pregnant, we're going to do the workup. Once you get to 40, we don't even say try, just go directly to your infertility specialist for likely IVF. How do we evaluate infertility? So I think this is the biggest frustration for a lot of us career-centered women is there's actually no test that can say, are you fertile or not? We do have some tests, anti-Müllerian hormone and a day 3 FSH or follicle stimulating hormone and estradiol level. However, those tests in all the studies are used to evaluate the success at in vitro fertilization. So there are no studies looking at taking a random woman with no infertility issues, never tried to get pregnant, testing her AMH and correlating that with overall fertility success. All of these tests have to do with like success with IVF. So can we extrapolate and say, oh, my AMH is really good, I'm gonna have no problems getting pregnant? Well, obviously in women, there's more than just her eggs, right? We worry about age and eggs, but obviously your tubes have to be open, your uterine cavity has to be normal, there has to be normal sperm. So there's so much more. And so we don't really have great data to say AMH or FSH is going to tell you, oh, sure, you can wait till you're 38. There's no data to support that, unfortunately. And the biggest thing is age. Age is really our best predictor of fertility, regardless of these numbers. There are some reasons to be evaluated sooner for infertility. If you know you have endometriosis, or you have a history of pelvic inflammatory disease, or you have PCOS, or you have obvious male factor infertility. Those would be reasons where obviously you should be seen sooner. And in addition, you need to be having regular periods. If you're not having a regular monthly period, you are not ovulating. So I wouldn't waste trying for 12 months if you're not having a monthly period. Having a regular monthly period is pretty indicative of regular ovulation. So the age factor. The one good thing about being on Zoom is no one can stand up and walk out or throw tomatoes at me. But female fertility declines significantly with age. If you look at someone in their 20s, every month that they have unprotected regular intercourse, they have about a 25% chance of conceiving each month. That is about cut in half by the time a woman gets to about 35. And by the time you get to 45, her chance is about 1%. So it declines pretty rapidly once you get to your mid-30s in terms of a decline in fertility. That is coupled with the fact that the miscarriage rate increases exponentially with age as well. The most common reason for miscarriages is abnormal chromosomes. And as a woman ages, her risk of chromosomal abnormalities increases. So if you are lucky in that 1% to get pregnant at age 40, you have about a 50% chance of miscarrying. So fertility declines and miscarriage rate increases. And that's kind of the downer news. So let's get into the talk about fertility preservation techniques. So in general, we think of there's three main types of fertility preservation. So there's oocyte preservation, which is egg freezing. So you take medications to stimulate your ovaries to produce eggs. They do an egg retrieval. It's usually done with a vaginal ultrasound probe that has a needle to it. So they push the ultrasound probe right up to the ovary, and they take the needle and they aspirate out the ovaries. You then freeze the freeze the eggs. I'm sorry, egg retrieval. So this is egg freezing. So there's no sperm. They don't create embryos. It's just eggs. Embryo cryopreservation is where you do the same way to get the eggs, but then you combine them with sperm to create an embryo. So you basically undergo the in vitro fertilization process, but instead of implanting them right away, you can just freeze the embryos. And then the last one is ovarian tissue banking. Ovarian tissue banking is typically reserved for more medical indications, such as cancer treatment. It's considered non-experimental since about 2020, but typically it involves removing a healthy ovary, cryopreserving it, and then re-implanting it, typically after remission of some cancer or disease. So that's typically more used for medical reasons. When we talk about someone who wants to consider egg freezing because they're 35, they're not married, and they're concerned about their decline in fertility, we usually call that social egg freezing. So it's non-medical egg freezing. Usually women will undergo this because of professional reasons, personal, financial, or psychological reasons. And really the most common reasons to do this are women who are pursuing a career and they don't have a partner currently. And so they're not ready to have kids yet, but they're concerned about their decline in fertility. This is considered elective, you could say. So most insurance companies will not cover social egg freezing. Obviously, if it's for oncofertility because of a cancer diagnosis, then it would be covered. So this has increased pretty exponentially. ASRM, which is the Society of Reproductive Medicine, as of 2013, it was no longer considered experimental. And so it's really increased pretty dramatically since 2013. So when we think about social egg freezing, should I freeze my eggs because I'm in residency or I'm pursuing a career, etc.? It's usually broken down into three big questions. When should I do it? How many eggs do I need? And then, of course, how much is this going to cost? So we're going to go through these three questions. So what is the optimal timing? So I'm going to go through a plausible snapshot of a woman who wants 2 children. So she's 32 here on the left. And we're going to see the green line is she freezes her eggs, and the red line is she doesn't. So at 32, her fertility is pretty good. So let's say at 35, she gets married. At 37, they say, let's try for our first baby, and no problem. They get pregnant, they have a baby. Well, at 39, they're like, let's try for baby number 2. And what do you know? She can't get pregnant with baby number 2. So she sees the infertility specialist, they pursue IVF. Well, the problem is now at 40, her chance of success with in vitro fertilization of her 40-year-old eggs is probably about 20%. So she has about a 20% chance of this working because of her 40-year-old eggs. If she had frozen eggs at 32, she would have about a 50% chance of being successful. So that's where you kind of get to this, where you're like, well, the earlier I do it, the better my eggs are going to be, but then I might be paying a lot of money for no reason. So here's kind of another way to look at it. So bear with me. I know this is a lot of bars. So this says at 25, do I freeze eggs or not if I plan to use them in 7 years? So at 25, if you plan to use them, if you plan to have a baby in 7 years, if you freeze them or not really a difference, right? You're going to have a 90% chance of conceiving with your own natural eggs or your eggs that are frozen. So not much of a difference. Again, 27, not much of a difference. It's really when you get to like 35 that you see that more dramatic difference, and even 37. Whereas at 35, if you're not ready to have a baby yet, if you plan to wait 7 years and you don't freeze your eggs, your chance of being successful drops pretty significantly to 40%. Whereas if you freeze your eggs, you can increase that pretty significantly. And you see at 37 and 39 how it's even more dramatic. So there's pros and cons. So the advantage of freezing your eggs earlier is that you're going to have better quality eggs and they're going to be more likely to be successful. The downside is you might be putting out a lot of money and never needing them, because at 25, you could get married in 2 years and never need this. So I like to think of it almost as an insurance policy, right? It's like a life insurance. Am I going to need this or not? So a lot of it comes down to financial resources. So how many eggs do I need? So we're going to look at this funnel to kind of explain it. I know a lot of people are like, well, I have 1 egg, I'll get 1 baby, but it doesn't quite work like that. So if you do an egg retrieval and you get 15 eggs, once they are frozen and then you go to use them and you unfreeze them, you're going to lose a few in the unfreezing process. Then not all of them will be fertilized. So if you started with 15 and let's say 13 made it through the unfreezing process, well, then only about 10 will actually get fertilized. And then only half of those will actually grow to become embryos. And then here's the really tricky part. Only half of those will be chromosomally normal, and that's going to be age dependent. And then that'll lead to about one chance of 1 live birth. So 15 eggs gives you a good chance of having 1 baby. So we talked about the age issue and the rate of miscarriage. So the younger you are, the more likely your eggs are going to be chromosomally normal. So at 25, 75% of your eggs are going to be good. 25% will be abnormal. But when you get to your 40s, about 80% of those eggs that they retrieved are going to be genetically abnormal. So this kind of is a good graph that tells you like, well, how many eggs do I need to have a good chance of having a baby? And this gets you all the way to a live birth, right? So if you're less than 35, you can probably get away with 14 eggs to have a 70% chance of taking them a baby. If you really want to have like a 90% chance, you can get 26 eggs, right? However, if you're 38, 40, 26 eggs only gives you about 70% chance. And so you can see the older you are, the more eggs you're going to need to give you a good chance to bring home a baby because of the risk of chromosomally abnormal eggs. Okay, so this kind of looks at what's the percent of women who got the optimal number of eggs in 1 cycle, in like 1 egg freezing, stimulation, retrieval cycle. And so as you see, if you're younger, you're more likely to have better ovarian reserve, you're more likely to get more eggs, and you need less eggs to bring home a baby. So if you're less than 34, you have a pretty good chance of just needing 1 egg freezing cycle to get enough eggs. However, if you're older, you're often going to need more cycles. So how many cycles? This is kind of a model that you can use. So let's say if you're 38, you're probably going to get an average of about 9 eggs from each cycle, which only gives you about a 30% chance of bringing home a baby. So you probably need to do 2 to have about a 75% chance of bringing home a baby. So you see that you can look at the ages to kind of see how many cycles do I need to have a good chance of bringing home a baby. And once you get over 40, you probably are looking at 5 or 6 cycles. Okay, so now the big question, how much is this all going to cost? So bottom line is it's about $31,000, but that's not paid all at once. So you can see here where the cost breakdown is. So initially, when you first undergo your egg cycle stimulation, you're going to do stimulation meds, which is about $3,000, the egg freezing process, which is about $10,000. So you're going to be about $13,000 each egg freezing cycle. Then you need to store it, which is about $500 a year. So you're looking at about probably 15, 12,000, maybe upfront. The remaining 18,000 comes from when you complete the process of in vitro fertilization to add the sperm, make the embryo, and then transfer the embryo. So it's that whole IVF process that doubles that cost. Okay. So kind of in summary, when, where, cost, logistics, ethical considerations. Okay. So in general, when we look at this insurance policy, decline with age, etc., 37 tends to, in studies, be the sweet spot, where if you are 37 years old and you do not have a partner, or you are not ready to have children, that is probably when it's most cost effective to say, now I should go and do an egg freezing and freeze my eggs. Younger than that, you can absolutely do it. It's just the younger you are, the less likely you are to actually cash that in and use it. So it's completely up to you, but that's kind of the sweet spot of where we think that if you're not in a relationship and ready to have children, that's probably where you're going to get the most bang for your buck in terms of utilizing them in the future. Logistics. Most infertility workup and evaluations are covered by your typical insurance, and that can be done with just your general OBGYN. Some insurances will cover in vitro fertilization if you have an infertility diagnosis. You've tried, been unsuccessful. However, social egg freezing for non-medical reasons, solely for this insurance policy, is typically not covered by standard insurance companies. So some boutique insurance companies, such as like Apple, advertises that. Facebook has said that. Spotify, some of these boutique ones will say, we'll cover up to $30,000 for egg freezing. However, I do have some concerns about that, only because I would hate for these companies to say, we're going to cover your egg freezing, so don't take maternity leave and leave because we want you to keep working. So again, it's sometimes I get concerned that they're preying on this vulnerable population to cash all this money and freeze eggs because of that fear factor. Whereas obviously men don't have these concerns. Okay, I do want to share a few resources with you. So resolve.org is the National Infertility Association. And there is this I want to, and you can learn more about infertility, know what my options are, find financial resources, find an expert, etc. So it's got some information. The other useful website is SART.org. And this is the Society of Artificial Reproductive Technology. And they have two useful tools. Sorry, my dog is snoring. Go sit down. And so you can do predict my success, and you can go in and you can put in your age and all the stuff, and it can help you predict success. And then there's also a find a clinic, and you can find a clinic and it'll also give you their success data for that specific clinic in terms of their IVF success rates. And then there is Fertility Within Reach, which does have grant and discount programs that are available to people needing fertility services. All right. I do want to take a minute. I would be remiss if I didn't take this opportunity or platform to remind you all to take care of yourselves and get your breast cancer screening. I got looped into this because I met Dr. Canada and Dr. Van Nortwick, who do a lot of breast cancer research. That's how I met them. So breast cancer screening guidelines are very confusing. There are 4 different organizations that all recommend starting mammogram screening and different interval screening differently, which I think does a disservice to women because they just get confused. Dr. Canada and Van Norwick have done studies that show that female orthopedic surgeons are at higher risk for breast cancer because of the fluoro you do regularly, and many of the lead shields you wear are not fitted for women, specifically petite women, and they don't always cover the axillary area, which is where most breast cancers are found. So for female orthopedic surgeons, I encourage you all to follow the most conservative guidelines, which is actually ACOG's guidelines, American College of OBGYN, which recommends self-breast awareness, which means what used to be self-breast exams, but it just means you should be aware of your breasts. Where do you have fibrous tissue? Where do you have more dense breasts? What's normal for you? Clinical breast exams annually, starting at age 25, and that's probably with your OBGYN. And then annual mammogram starting at age 40. So I know I have people here who've already completed childbearing, but I think it's important that we be the change we want to see in medicine. We are the mentors that will be leading this younger generation as they go through medical school and residency. And so we need to take care of the women, the female surgeons behind us. We need to educate them. We need to advocate for policy that encourages them to have children during residency, take appropriate maternity leave, probably in their 3rd trimester. They should not be working crazy hours, but really build families so that they don't have any regrets later on. And now I'm happy to take questions.
That was awesome. Thank you for sharing that invaluable information. So the question and answer is open, and so anyone feel free to put some questions in the chat or the Q&A, and we will get to the ones that we can. So
I see a couple here. Does egg retrieval lead to an earlier menopause? Egg retrieval does not lead to an earlier menopause. There were some studies that showed if you had multiple cycles of IVF or egg stimulation that it perhaps increased the risk of ovarian cancer, but I don't think that's been well published, but it should not affect any menopausal status. The next question says, can anyone speak about their experience using a surrogate or about how to receive compensation in an RVU-based model with or without surrogate during pregnancy, please? I know surrogacy can cost close to $80,000, but I don't know. I can't speak to any experience if anyone else can.
We have another question here too. Is freezing embryos better than eggs if we do have a partner, but
Yes.
are putting off childbearing due to residency training?
Yeah, so if you have a partner, embryos are going to do better in the process. So if you have a partner, I would go ahead and do the IVF process and freeze the embryos. You can even genetically test them then and there in the process. So I do think if you have a partner, that's going to be better off to freeze embryos than to do the oocyte or the eggs by themselves. You mentioned reasons to check fertility sooner and possible man infertility was listed. Oh, for male infertility. So yeah, cryptocortism, if they have varicoceles, any of those things can impact male fertility. Male fertility is actually very easy to test. Literally, it's like, are there sperm and are they motile? So you can easily get a semen analysis. It's like $100 and you can check a man's fertility. If they can ejaculate, there is sperm present, normal count, and the normal motility, they are fertile. For men, it's simple. For women, we're more complicated, right? Like our hypothalamus has to talk to our pituitary, which has to talk to our ovaries, our fallopian tubes have to be open, our uterine cavity has to be normal, the sperm has to be able to get through the cervix. Like there's so much more for women. So that's why it's harder to say there's no like one test for women. But for men, actually, there is one test, the semen analysis. Is there any evidence that having an IUD extends the fertility period? No. So the only contraception that delays return to fertility is Depo-Provera. So Depo-Provera, if you use that for contraception or for treatment of heavy periods or endometriosis, it's very effective at suppressing periods. But it's a huge dose of hormones. And so it can really suppress that hypothalamus for up to a year, even one dose. So if someone comes in and says, I haven't had a period for 6 months, and they've had a Depo shot, we will not do a workup for 12 months after their last Depo shot. So that's the only one that delays fertility. Every other form of contraception should have no delay in return to fertility. Legitimately, you can take out an IUD and conceive the next day because it doesn't impact ovulation. And then birth control pills as well. Oftentimes, the infertility specialist will put you on birth control pills just to time a group of people up together. So that should not delay it. How is the schedule of egg freezing? So egg freezing is pretty quick. They can do some quick starts. The biggest time suck is they usually want you to come in first thing in the morning for daily scans to monitor the eggs, because they want to catch the eggs before you ovulate. To do the egg retrieval, they want them to be mature, but they want to catch you before they ovulate. So, I don't know if I said that right. So they monitor the size of the ovaries, and they have you come in daily for scans. So that's usually the biggest like time portion of having to come in every morning. So, sorry, the next question is it similar cost to freeze embryos instead of eggs? So freezing embryos is going to be more expensive in the upfront, because you're going through basically the entire in vitro fertilization process. So you're probably going to spend almost that entire $31,000 upfront to freeze the eggs and to freeze the embryos. And then it won't be very much money to then just transfer the embryo later. So freezing embryos is going to be more of an upfront cost, whereas eggs, the cost is half upfront and half when you use them and you complete the IVF process. Did I answer that? Okay. How do you navigate storing eggs in one geographic location, but then ending up working physically elsewhere when you want to use them? Freeze my eggs in med school in Nebraska, but move away. Actually, this is, it's actually easier than you think. People do this all the time. People move eggs, embryos. They are able to do that. So wherever you do your egg freezing or wherever you do your embryos, they oftentimes aren't even storing them in that clinic. There's like a central storage place. So they will get them to you where they need them. Different providers or guidelines have different definitions for irregular periods and ovulation. Yes. So a normal cycle is technically considered 21 to 35 days. So if you have a regular period the time between the cycles is between 21 to 35 days, textbook, that is a normal cycle. With that being said, the average cycle is 28 days. If you're unsure if you're ovulating, you can always use ovulation predictor kits. Those you can buy at any drugstore. Don't go to Walgreens. We don't like Walgreens anymore. Not Walgreens, but any other drugstore. And you can, where like pregnancy tests are. And you can, you basically pee on them after your period ends, like starting day 8, 9. And it'll turn colors based on the LH surge, which precedes ovulation. So it'll tell you like you will be most fertile in the next 1 to 2 days. So you can use that if you're like trying to get pregnant and to see if you're ovulating. Okay. Is there any further information as to why more than 12 hours in the OR week leads to higher complication? No, that's what the study chose to look at. So I don't know where that came from. I mean, I will say my residents still work 80 hours up until delivery if they don't have complications. But obviously, like one of my residents had developed preeclampsia at like 32 weeks. So we pulled her off. So if obviously everyone's different, but yeah, I don't know. Any known literature of X-ray radiation on eggs, specifically during the egg freezing process? Oh, that's a great question. I am happy to look at it. Is Dr. Van Nortwick here? She might know that. She's the radiation expert. I don't know that, but that makes sense that if we're stimulating the eggs, they would be more sensitive, but your lead shield should protect you from that. Do you have suggestions how to plan for pregnancy and the time constraints in residency? I know this is so hard because it's so hard to say, like, are you going to get pregnant month 1, month 2, month 11? And I have terrible reproductive planning. I had 2 boys they're 7 days apart in December. So I get it. It's so hard to plan the pregnancies because yeah, like my first one took me 9 months. My second one took me an hour. So it's so hard to predict pregnancy, but I would just say there's no perfect time to have a baby. There's always going to be something in life that happens. what I want to advocate for is whenever you think you're ready, you're married, you're financially stable, try and get pregnant. And if you need to take 6 months out of residency, I know right now you're like, that seems like forever and I can't be delayed 6 months out of residency. But you know what? It's not the end of the world. That those first 3 months when you're breastfeeding and having that bonding time with your baby, you can never get that back. You can get back 6 months of training. So that's what I would really advocate for, is if you feel like you are in a relationship place where you want to have a baby, go for it. What is your recommendation for medical student residents planning to delay childbearing until after training? Yeah, so 37, well, it depends. If you're married, I wouldn't wait. I would go for it. If you're not married and you don't have a partner, 37 seems to be when my colleagues and residents are doing it. That's what most of the data say it's like cost effective. If you have like, if you're Kim Kardashian and you have tons of money, then yeah, do it at 30. If you have like $40,000 to just throw away. But if you're like most of us and you don't have that kind of money sitting around, I think 37 is reasonable in the sense that if you are 37 and you're not married and you're not ready to start trying to get pregnant, you are likely going to need infertility services. And so if you can freeze the eggs now and have those, because you're going to pay the 40,000 at some point, right? So just pay the 15 up front to get the eggs that are going to give you better chance of success, then I would do that at 37.
All right. Any last questions before we wrap things up? That was an amazing Q&A session. You got through like 15 questions. I'll give it one more sec for any last questions. Here comes one.
Does anyone know the effects of cement on the eggs during the retrieval process? Should I avoid joint replacements during this time? I don't even know what that means. And I don't know what, I didn't know you guys do cement. So I don't know.
Yeah, I haven't seen any specific studies on how it can affect eggs, but something we can certainly look into. That's a great question.
Yeah, I mean, the only other thing that I would say during the egg retrieval process is your eggs do get really big. And so sometimes you can be swollen and be like somewhat tender. So I know you guys like take trauma call. That might be somewhat challenging if you're like bumping into things and moving things around because you're like swollen and yeah, enlarged belly. That would be the only thing I would think that may make it a little bit challenging. But they can usually do in 2 weeks. You can be, I don't know if I completed that thought about the time constraint. In 2 weeks, you can usually do a stimulation and get your egg retrieval and be done. So that can actually happen pretty quick. The whole IVF process is a little bit more complicated because then they have to form the embryos, grow them to a certain level, and then time the transfer. But that's why if you freeze embryos, then you can come back and do a transfer whenever. They just have to prime the uterus with hormones.
Incredible amount of information. Can't thank you enough for your candor, your insights into fertility, which is really vital information for all of our young, amazing women in orthopedics. So really thank you for taking time away from your family and to be here and to provide us with all this information. We really appreciate it.
Yeah, thank you so much for having me, and get your mammograms.